Well, thank you. I'm really happy to be here. I'm a little taller than everybody else. Are you picking me up? Okay, because I'd like to take a little bit of a step back. Is that okay? Okay. All right. Well, why is this titled Putting the Mouth Back in the Body? How did the mouth get out of the body in the first place? And so we have to just touch a little bit on history and the schism between medicine and dentistry. What happened? How did they get separated? How many people here have wondered why their dental insurance is separate from their medical insurance? Right? How many people know why? Well, guess what? You're gonna get to learn. So the separation of medicine and dentistry, it dates back several hundred years. In dentistry, we like to talk about Paul Revere as America's first dentist, because dentistry was practiced by blacksmiths, which is what Paul Revere apprenticed in. And it was also practiced in barbershops. In fact, if you go to the dental office, you'll never see it the same again. It looks like a barbershop, right? It's open air, multiple technicians, clinicians working on chairs, no privacy. But it was a trade. And so there was some bias and stigma associated with that. Now, dentistry was practiced by physicians, and it was even considered like a specialty in medicine. So when people showed up in a hospital and they had dental issues, physicians would treat them, but on the everyday, particularly for the lower class, it was being addressed as a trade. So when the University of Maryland proposed that a dental school or a dental specialty be introduced at the School of Medicine, it was denied. And so then started the very first dental school called the College of the Baltimore College of Dentistry in 1840. So we started this split of education. And so the education was completely separated. If we move forward into when insurance models came about, medical insurance was really focused on the catastrophic, the large, sort of unpredictable events. And dental insurance was for preventive care. It was meant to be predictable. And then when the government got involved in public insurance models, Medicaid, Medicare, the American Medical Association and the American Dental Association fought hard against that. The American Dental Association won that battle, and still to this day, dental benefits are not federally mandated as part of Medicaid, and dental benefits are not in Medicare. So states get to decide whether they have dental benefits at all, and to what extent they have dental benefits. What else can I tell you? The American Dental Association was formed in the 1800s, and it excluded any non-white dentists until 1967. And it wasn't until 2013 that there was a formal apology made for those exclusionary practices. So there are a lot of consequences that come into play, and let's talk about them. Documentation and charting. So the electronic dental record came long after the electronic health record. In fact, some of your dentists may still be using paper charts. It's still a common practice in dentistry. And what that means is coding and billing are also separate. So you see this sort of like organizational schism between medicine and dentistry. So you can't really develop clinical databases that have oral health and medical health in them. So you can learn a lot about oral health, or you can learn a lot about medical health, but you can't learn about them very well together, and you can't do good research. Population surveillance. National Health and Nutrition Examination Survey started in 1960, and Haynes. Dentistry showed up very briefly in 1970, came immediately back out, went back in 1988, came back out, and it wasn't until 1999 that it became part of the continuous population surveillance. So we haven't had a good sense of what population oral health looks like for the last centuries. And we're just starting to learn. And if you look over here, this is a diagram that I like to use that shows all of the inflammatory comorbidities that are associated with periodontal disease that have been represented in studies. So the mouth is important to the body, but because we're not taking care of it, oral health owns the largest population disparities in health. So disparities are a very big deal in oral health. We also have really bad workforce diversity. Black men are significantly underrepresented in dentistry. In Utah, 96% of dentists are white males in Utah. So we don't have a lot of diversity, and there are impacts of that. There's also been an impact on research. So there is a dental institute, the National Institute of Dental and Craniofacial Research at the NIH, the NIDCR. It does exist. It's small. It's where I happen to get all of my funding, which is great, but it's very small by comparison. And yet we all have dentistry, right? Not a single one of us has never been to the dentist or had a dental issue that had to be addressed. So there's, Kathleen talked about women's oral health in the crosshairs. This is the crosshairs. And women get really affected and impacted by this schism between medicine and dentistry. So I just want to bring up a few highlights from my own research that really are driven by this history that is so important and gives meaning to what we're seeing on a population level in terms of oral health. So what do we know about gender and race? So we know that racism or race, it's been associated with poor oral health. And we know that men and women have been shown to experience racism differently. So there's a whole body of research on that. In fact, there's a lot of research about gender and racial biases in pain management. Brave men, emotional women, right? We're hysterical, right? Too much emotion, and it's not real. Our pain is not real. African Americans, in particular, they get less aggressive pain management. And who's ever had pain at the dentist, right? Okay. So in fact, 1 in 7 is estimated. There's not good data on this, but it's estimated that about 1 in 7 people have a dental care related fear or anxiety. And that prevalence among middle-aged women, however, may be as high as 1 in 3 individuals. And we know that this has an impact on the oral health of women because women relative to men have much more untreated decay occurring in their mouths. And you get this vicious cycle of dental care related fear and anxiety that makes you avoid the dentist. Also, we know that women have been historically excluded from research, right? They're underrepresented in research. And when they have been included in national surveillance initiatives, oftentimes the numbers at the intersections are not enough to have meaningful investigations. So I looked at NHANES for dental data. I wanted to look among Black women, and there were less than 500 Black women in the NHANES population. And that wasn't enough to do the things that I wanted to do and what I wanted to investigate. And this really speaks to the importance of female-based cohorts. So thankfully, I came from Boston a year ago where I spent 20 years working, and out of Boston University is the Black Women's Health Study. This is a national cohort of nearly 60,000 women. They've been followed since 1998 through biennial questionnaires. I love the way they recruited women. So they recruited women by getting subscription lists to Essence magazine, and then they enrolled their friends and family and got this really robust, very committed cohort of Black women throughout the US. And in 2005, I started working with them to introduce some brief oral health measures. And then in 2016, we said, you know what, we need something way more in detail. So we're going to drill down on the nearly 1,000 subjects that live in Massachusetts, and we're going to do a really detailed oral health questionnaire. And then we're going to bring them into the clinic and look at them clinically, validate all the self-report measures, et cetera. So one of the things that we looked at, so this being a cohort of Black women, repeated measures of everyday and lifetime experiences with racism. And one of the things we measured was this big battery of dental care related fear and anxiety. And we wanted to look at whether experiences with racism, thinking about the population, the dental care workforce, and the known patterns of utilization, we wanted to look at the relationship between racism and dental care related fear and anxiety among this cohort. And those who had had lifetime experiences with racism had a 72% increase in the odds of high dental anxiety. And high dental anxiety in this cohort was twice that of the prevalence found among white women. And what was really interesting is that when you looked at the fear-inducing stimuli for that dental care-related fear and anxiety, across the board, we didn't see anything unusual. Cost, people are worried about cost because why? Insurance models don't cover restorative dentistry at a 100% cost. Many of you have probably paid $500 out of pocket for a crown, and that's a cheap crown, right? So cost causes a lot of anxiety, particularly among caregivers, right? Caregivers of young children. Cost is a big deal. None of us like needles or injection. We don't like to be in pain or discomfort. So that's very typical. But if you look at those that had high relative to low dental anxiety, you see a difference in terms of what was most important. So you get pain and discomfort. So recall pain management among women, particularly Black women. You get an unkind or an unsympathetic dentist. There's racial and gender discordance between the patient and the provider. You get a feeling of a lack of control in the dental chair. Right? So it was very revealing to think about, well, how do we tackle oral health disparities when this is the case? We have a lot of work to do. So we also looked at perceived experiences with racism over time. So again, this is a longitudinal cohort. So we looked at declines in self-rated oral health related to experiences with racism. And we found that you get, with increases in everyday racism, so in the top quartiles, you get a 50% increase in the incidence of oral health decline. So these have been some interesting studies that have really got us thinking about how do we address women's oral health, particularly among disparities facing populations. All right, women. What does oral health have to do with reproductive health? Well, this diagram shows two different hypothesized mechanisms about how inflammation in the mouth affects the adverse pregnancy outcomes. One is that the bacteria gets into the bloodstream and travels to the reproductive organs and can cause premature intrauterine restriction. And one is that you have distant low-grade inflammation in the mouth that causes inflammation-related issues in pregnancy. However, sorry, you can get it from me later. However, why did we start thinking about this? So in 1996, there was a study by Offenbacher who showed that in a small sample of women, those who had periodontitis, inflammation of the gums during pregnancy, had as much of an 80% increased risk of preterm or low birth weight outcomes. and it was highest among Black women. So then that was so alarming that it was followed up by several studies, to the point that the Journal of Women's Health was like, come on, can we move on? Right? Like there's, what are we finding here? Because there had been clinical trial after clinical trial, a Cochrane review, and treatment of periodontitis during pregnancy didn't have an impact. And so what are we doing here? And the thing that the CDC learned as the most informative from all of this work that was done was that it's safe to treat periodontitis during pregnancy. But the real problem here is we don't have cohorts of women to study oral health in relation to reproductive outcomes. The second trimester is too late. By the time they're in their second trimester of pregnancy, we can't do anything about it. In fact, we may be causing harm by disrupting the bacteria in doing treatment in the second trimester of pregnancy. So again, I was very fortunate to be in Boston, where I got to start working with this large North American cohort, a fertility cohort called the Pregnancy Study Online, or PRESTO for short. It's approximately 20,000 women throughout North America, started in 2013. And these are women who are planning a pregnancy. So they identify them pre-conception, and they are able to measure all of the potential informative covariates that might impact fecundability, as well as adverse pregnancy outcomes. And I said, you know what, why don't we just ask about oral health? Oral health wasn't on there. Let's ask about it. So we asked some clinically validated self-report measures for oral health starting in 2019. And pretty quickly in 2021, we were able to publish in Human Reproduction showing that preconception periodontitis resulted in a delayed time to pregnancy. So there were declines in fecundability as a result of periodontitis. We also followed that up with a paper that looked at risk of spontaneous abortion, and also found that miscarriage had a higher incidence among women with preconception periodontitis. And I have current NIH funding right now to continue work with this cohort, where we're looking at gestational diabetes, gestational hypertension, eclampsia, as well as preterm and low birth weight outcomes. And then this observational work will be followed up with a new enrollment of a clinical cohort where we can get women preconception, look at them clinically, and then follow them through pregnancy. Okay, finally, I also spent a lot of my career in the Boston public housing projects. This one was not far from my office, about a quarter mile down the street. And in Boston, the Boston Housing Authority was the largest landlord in Boston. And as you can see from this picture, it's tightly clustered units, ranging in size, but it's a lot of poverty, and it's a very diverse population. Now, about 80% of these households in the housing projects are headed by women. And women who live in public housing, they're twice as likely to be obese and 3 times as likely to have diabetes. So a lot of chronic disease happening in these housing projects. And if you look at their socioeconomic counterparts that are not living in public housing, but they're living in private residences, those in public housing are more likely to be women. They're more likely to be non-US born. They're more likely to be caregivers of minors and less educated. And so I started thinking about, well, what's the social influence aspect happening here? And started to do social network science. And social networks have been sort of hypothesized to be those translating mechanisms of upstream influences to downstream behaviors. And so we have a lot of studies that model social networks in public housing. And what we find is that oral health status and the risk behaviors of these caregivers of women relative to their children, they're socially clustered in ways that could be contributing to these disparities. And oral health status, again, because it's so separated from medicine, it's hard to figure out, how do you navigate it? How do you find care? Well, oral health status may be a central factor in the formation of social networks. And we've also found that Carrie's risk behaviors are also socially clustered phenomena, and there's a strong potential here for network interventions. And what's really interesting when I talk about oral health, forming these social networks, what we found is that these women are generating what we call weak ties. And these weak ties are providing them with resources and support. So if you've ever heard of the Granovetter paper, the 1973 Granovetter paper about the strength of weak ties, that's what we're seeing with oral health. Women are associating with others in order to get resources, information, and support relative to their oral health and the care of their children. We've done this in qualitative studies as well, where we've been able to see them talk about the importance of their social networks and being able to navigate oral health conditions. And we have a paper that's about to come out that shows that COVID, one of the things with weak ties is they're vulnerable to disruption. And so we saw a loss among women who had fair or poor oral health, a loss of those weak ties due to COVID. And so we suspect that we'll see further declines in oral health status because they're losing their resources and support, and those have been disrupted. So let's get the gang back together. Let's reunite medicine and dentistry. That is the key mission of the School of Dentistry here at the University of Utah. And we have a number of things that we're trying to do to bring medicine and dentistry back together. That's why I'm here, is because it's a key passion of mine. And if we do that, we can better support women's overall health. Thanks.
How about questions? Questions. And remember, you've got a little button that you can push if you have any questions. Yeah, Nikki.
Thanks for this great talk. So it had me wondering, is there research to support the dental spas that where you get your hand in paraffin wax? Maybe you get the...
I'll stop you there, no.
Okay.
Evidence-based dentistry is still a very emerging field.
Well, I have a question about cosmetic dentistry. So is there a difference between men and women in how they access cosmetic dentistry?
I would suspect so. However, there is no way to study it because we don't have any databases. I mean, we'd have to launch a study on that, probably a survey study of some sort to be able to measure that. But dentistry's been very careful to keep itself segregated from medicine. They want all the benefits and none of the burden. And so it's political. There's a lot of reasons that there's been a push to keep dentistry separate. They want their autonomy. They want to be able to do their cosmetic dentistry. They want to be able to charge as much as they want for it. And if you want a history on the dental school, the reason the dental school was started here at the University of Utah was to care for the underserved, to care for those populations that Utah dentists were not caring for. And so that's why in our clinics here, we see more than 40,000 patients per year, and they're all underserved. So we treat Medicaid patients and patients who cannot pay. We have a philanthropic fund that covers a lot of the care. So,
well,
sorry.
You. Oh, Nikki,
And how do we get more women in dental school?
Great question. I wish I had a specific answer. We need women in dentistry, and there's been a lot of mechanisms that have gone towards that. I'm lobbying the NIDCR right now based on a workforce working group that I've been involved in, trying to get funding for women for pipelines for women in dentistry. It's actually gotten a whole lot better. In fact, we have a 50-50 split men and women in our dental school here. It's getting a whole lot better. We need more diversity. We need women who come from underrepresented groups in dentistry. And we're working with an NIDCR R25 program to try to get them summer research programs, pipelines to dentistry. We do training programs, et cetera. It's the gender diversity in dentistry has gotten a whole lot better. And then we need to move to trauma-informed care because that doesn't exist in dentistry. right? Okay, sorry.
Well,
Soapbox.
and is there any effort, do we have a dental hygiene school here?
We have lots of dental hygiene schools in Utah, not at the University of
Well,
Utah.
it'd be good to have one, because for many people who have dental anxiety, they're afraid of the dentist, but they're not afraid of their hygienist. And getting a hygienist might be the access into underserved people.
Yes. So that's another political issue. There's this position called a dental therapist, which is like a bridge between a dental hygienist and a dentist, where a dental therapist can engage in restorative dentistry. It has not been approved in Utah, and there's a big push against dental therapists.
Well, for all of us who really support nurse practitioners and how much they have enhanced the quality of care of women, I'd say if there's any equivalent in dentistry, we should definitely make that push.
Yes.
So I'm sorry, I can't figure out this microphone, but hopefully I'm speaking loud.
Yeah.
I was just wondering if you have published anything about your experiences working with this almost exclusively underserved population of 40,000 people. You've got any publications? Repeat the question.
Yeah, so she's asking about the work that the dental school does on these, more than 40,000 patients per year. So I'm actually writing an R01 right now. I'm like this close to getting 10 years worth of Medicaid data so that we can study the effect of oral health policy. Oral health policy is great here in Utah. That's a positive thing. We have comprehensive dental benefits for Medicaid populations. It's been approved it was approved in the 2023 legislative section. We're taking over all adults in Medicaid. We currently have blind and disabled, elderly, and targeted adult Medicaid with substance use disorder. So now's the time to start doing the research to show the impact of that increase in access on these populations. I'm also working with our dental databases. I have a meeting with Reed Barney almost every 2 weeks, who's the director of the Enterprise Data Warehouse, so that we can develop a clinical database with which we can study the oral health needs of these populations. So yeah, it's all coming down the pipeline. Yeah.
Thank you. Thank you very much.